All right. So good morning, good afternoon, and good evening, everyone. Thank you for joining us for our February of 2023 Global One Health Initiative webinar, supported by the NIH Fogarty International Center. And our topic for today is Assessment of Public Health Emergency Response in Pakistan. And we will be hearing from Dr. S.M. Mursalin, the Chief Executive Officer of the PAC One Health Alliance, and Dr. Shagufta Zareen, the Team Lead for Research and Development at the PAC One Health Alliance. I would like to briefly introduce our moderator, Christine O'Malley, who currently serves as Associate Marketing and Communications Director for the Office of Human Resources at The Ohio State University, and has been a longtime partner of GOHi, currently serving on our Faculty Advisory Committee. And with that, I will go ahead and hand it over to you, Christine, to introduce our speakers.
Thank you, Laura. I'm very pleased to introduce our two presenters today. Dr. S.M. Mursalin is a medical doctor with a Master of Public Health, graduate diploma in Health Systems and Development Studies from the International Institute of Social Studies at Erasmus University in the Netherlands. Since 2019, he has been serving as Chief Executive Officer of the PAC One Health Alliance. It's a national NGO affiliated with regional and international organizations working on emerging infectious diseases prevention and control, and particular with an emphasis on One Health projects. Dr. Mursalin has more than 30 years of experience in areas ranging from health information systems, disease surveillance programs, and other kinds of health systems. I would also like to introduce Dr. Shagufta Zareen. She is a medical doctor and public health specialist with a Master of Business in Human Resource Management. So we have that human resource link together, Dr. Zareen. She studied at the University of London and Oxford in the UK. Dr. Zareen has received education, including project management, global public health, and civil registration and vital statistics from various countries around the world. Dr. Zareen has been serving as the team lead for research and development at the PAC One Health Alliance since 2019. I would like to welcome you both. We eagerly await your presentations on the topic of One Health. So take it away. Oh, wait, one more thing I want to mention before we get to the presentations. We are going to do Q&A after the presentations, but participants should feel free to submit their questions using the Q&A button at the bottom of your screen. But we won't get to them until after the two presentations are done. So I don't know which of you wants to go first on your presentations, but if you want to go ahead and get started, that would be great.
Yeah, I think I have to, thank you very much. I have to go first. Can you listen me? Can you hear me? Okay.
Yes.
So,
Yes, we can hear you.
okay. I will be just giving you some introduction to our organization and the partnerships and some of the projects that we have we are implemented, and especially some brief on the, because there are some projects that we take pride in that, and those are like our flagship projects, and there are some other continuous activities. So I'll be discussing with you the AMR surveillance project, which is one of the very important projects that we have accomplished, and the ongoing project on One Health event-based surveillance program and its components on that. You see. So am I audible? It's okay?
Yes, we can
Okay.
hear you just fine.
Okay. So actually the areas that we work is certainly the most important area is certainly the One Health promotion for the curtailment, and this is one of our vision and this is slogan for curtailment of emerging infectious diseases while using the One Health approach. So the areas of interest is One Health promotion, One Health education, emerging neglected zoonotic disease, the risk communication for health outreach, infectious diseases, biosafety and security, One Health surveillance, which we are doing a project nowadays, foodborne and waterborne diseases, and some of the other areas that we have recently have been working or are in touch with is the COVID-19 pandemic readiness exercise and its response. And Dr. Zareen would be dilating more on that. And then the ecosystem health and the disease emerging through animal-human interface. AMR, antimicrobial resistance, public health. So these are the, because even One Health is such a huge canvas, so many topics here. You cannot do, move in all directions. Some of you have to set your targets and priority areas to work. You see, it's a much broader subject to deal with. So, sorry. So you see the main is One Health milestones or the areas that we have been working is the zoonotic diseases, the AMR. I think this is very important areas, these 5, the vector-borne diseases. So we have done some work on zoonotic diseases, AMR, vector-borne diseases, and these are the 2 areas, food safety and security. We have not sufficiently worked, but recently we have, regarding the environment, we did a study on the persistent organic pollutants. You see the POP in that, but we have done bit by bit in multiple areas. So how we do, certainly we are an NGO. We have partnerships, collaboration with more national organizations, some universities, academia, government organizations like Ministry of Health, the Primary and Secondary Healthcare Department, PSPU, some universities like University of Veterinary Sciences, University of Agriculture, Faisalabad. We have proper like MOU, and we are very glad to work with them in this, collectively in some areas. Certainly the main crux and the main message in One Health is the intersectoral collaboration, coordination. We have been working with international partners too. Ending pandemics have been our supporter, or have been sponsoring some of the activities important and giving us good support. Integral Global, Sandia University, Sandia National Laboratories. We have done this exercise. Dr. Zareen would be explaining. Fleming Fund EHAN is a Asian Health Information Network. The MFINET and WHO. So we have been coordinating in some way or other with these organizations. And with some of the organizations, we have proper, what I can say, a memorandum of understanding, long-term memorandum of understanding. So our implementing, there are 2 types of partners with us. One is the implementing partner, and other is the collaborating partners. One, we say implementing partners. It means those are, you see, we are all the time working closely with them, and very closely with them. And you see, we seek their advice, we work together, we discuss together. So, we plan together in this. And collaborating partners are those which are very critical for One Health domain. And but still they are not as closely working with us as the implementing partners are, you see. So, and the major projects that we have accomplished till today, we are in search of new projects. But I think some of the areas that we at this stage, we are working on 3 very important areas, where the deployment of One Health event-based surveillance project. Currently, the pink one are the projects that we are currently focusing on. We are working with the Infinite, which is a regional, you must be knowing about it, is a regional organization in Ambro region, Ambro WHO, which is working on One Health and different other disciplines. So we are working with them for the development of a regional One Health curricula. You see, that has a draft has been developed, and we would be finalizing it. And once it is done, probably we will be organizing some regional One Health workshops based on this curricula. This is a long-term curricula. We also developed ourselves some curricula, very short, condensed curricula, 3 days or 1 week. And this is to be run in the universities and public health and the veterinary universities here. But there is now, we are preparing a diploma program. And we did a study, as I told you, on the COVID readiness, and we are busy in action planning, developing, you see, go with the government, the actions required for strengthening of our readiness and resilience. We did an AMR study. I'll be just giving you an orientation on that. We did a health system governance mapping exercise in 2020 with WHO, partnership with WHO. We developed a national countries profile for hospital sector, which is, we worked with WHO EMRO. Health risk assessment per POP, you see the environment sector. We did a long-term project, 2 years, on vector-borne diseases and prevention and control. I'll just give you some 1 or 2 slides on that. Developed a mobile application for integrated vector-borne diseases. We organized a capacity building program on biorisk management in partnership with the University of Health Sciences, Lahore, where we worked with the tertiary care hospitals. First their assessment, and then you see the capacity building. And this was supported by CRDF USA. Leishmaniasis study we did, and that was in partnership with other regional countries. That was under the Bill Gates and CORDS. So these were the some main areas that we have been working in. Within these areas, there were many activities. So this is our journey. We started 2014, but we have been busy in between for a number of activities, a number of projects in partnership with the government and in partnership with the international partners. And this is, I think I've already explained, yes, this. These are some of our documents, studies, those have been produced, and the gap analysis study that we organized, the One Health Surveillance Systems a training manual. I explained a very short-term condensed training manual, and they're training a long-term training course. And then we organized workshops, consultative meetings, and we have been organizing their consultative reports. And because we organize such meetings on multiple topics, and all these are all documented and also part of our website. The vector-borne diseases, you see the tropical disease, neglected tropical diseases. We worked. This was like, again, a regional kind of an activity where we collaborated with a CICID organization based in Albania, and MFINET based, Jordan based, and Pakistan. The 3 countries, because these 3 countries were supposed to be high in leishmania, and the main areas that we looked at is the disease burden of leishmaniasis, cutaneous leishmaniasis in these countries, the institutional arrangement to address the problem, the competencies at the various levels, at the strategic and at the operational level of the health system. And then there were project objectives, and we look at the high prevalence districts in Pakistan. Similarly, similar idea, you see, focus or tools were used in Albania and Jordan. And then we have collaborative exercise discussions to share the experiences. And this exercise on this work was very well published in at multiple forums, and even in Lancet it was there. The CDC also, you see, ProMed, and multiple. It was very well, you see, promoted. The areas that we focused for leishmania the recommendations that we got for Pakistan specific, but because we had then Jordan and Albania specific also recommendations. Policy level, there was a need for it because this is what I can say, neglected disease, and not much work has been done on this leishmaniasis, and there is a big problem in some of the districts in the country, and there's a need for a long-term vision, advocacy, and strategic planning. At management level, we saw there was a shortage of drugs, and there is a local production production of the drug is not there. There has to be better coordination with other programs, with other vector-borne disease programs like malaria, dengue, leishmania control. At community level, the awareness, people were not aware about the cause of this cutaneous leishmaniasis and what to do and how to manage, and there was issues there. Again, we have a organization at the South Asian level, what we call as the South Asian Disease Network, surveillance network, which in with the aspiration, there is the collaboration, but certainly more it's a huge region, so and huge population, so a lot more work is yet to be done. But here we did a joint study, joint work on AMR. You see, South, and the main purpose of this South Asian network is to strengthen regional capacity, sharing of information, addressing cross-border disease surveillance issues, organizing trainings. So these were, and we have been meeting occasionally, like 3-4 meetings we have organized. But the good thing is that people, you see, the experts are already identified. We developed a directory of experts in these countries, and we have developed some good partnership, good linkages with these experts. So the AMR study was one of the important studies or important work that we did together with the South Asian region countries. That was supported by Ending Pandemics and also funded by Fleming Fund. And similar exercise was done in several other regions. I think all total 16 countries this was done. The main, you see, the area that we need to work, we have to work mapping and gap analysis needs, the current practices for common surveillance protocols. What are the protocols relating to AMR, which are being adopted? And uptake, establishing common protocols. The ultimate aim of this part was to develop, first to look at the surveillance mechanisms, what the status of AMR surveillance in the region and in the countries, and then to develop common protocols for data collection, analysis, interpretation. Because once we talk about the AMR One Health related surveillance, it means multiple, you see, the sectors which are you see, taking care where the you see the antibiotics are being used. You see, it could be agriculture, it is the veterinary livestock department, it is a health department, food security, food department. So there is being used in multiple. So all were involved. So we took care of our own country, Pakistan. Then there was Nepal and the Bhutan, the Afghanistan, FNet. They were doing using the same templates for mapping. And the piloting of the count, that was, you see, the main objective of this exercise. So this was, you know, the South Asia is a highly populated, you see, area region, and it is considered to be the hotspot of emerging infectious diseases. So there were organizations we work together, and we have good contacts and relations with these organizations like Pak One Health, MFNet based in Jordan. They worked in Afghanistan. South Asian MFNet also worked with us on, you see, this Lithuania project. And then the South Asia network, which is based at this stage, which is secretariat is in Bhutan. And then Nepal, they have been working very closely with us. So the strengths that we found in AMR in Pakistan specific, they're similar, you see, similar exercise was done in other countries, and they came with some other findings. Is the established intersectoral, so the strengths are, there is a intersectoral core committee, there is a strategic plan developed, there is an action plan developed in 2017, technical core group has been developed in Pakistan. There is a proper document where you see the budgetary support by the government has been provided on AMR National Action Plan developed. Sentinel sites were for AMR surveillance were developed in the province of Punjab and Sindh. Drug susceptibility testing is available in public and animal health sector, some of the sector, but AMR reference developed in public and animal health sector. National strategic and national laboratory strategic framework is available. There are focal, but you see the institutional mechanisms are visible, available, and these are strengths. But you see the in reality, lot of you see all the actions plans there are plans, but they are not completely implemented. There are real issues in its implementation, the field level. So the issues that the main problem, no central coordination for AMR partners. You see that coordination is missing. National AMR surveillance system. There are AMR focal points in the relevant sectors, but there is no national AMR surveillance system among sectors. See, institutional sharing of information is a problem. Awareness among health and animal care professionals on AMR is lacking. Antibiotic stewardship program is absent. Infection prevention and control program, though there are standard national guidelines, but the guidelines are not implemented in the field and at the strategic and operational levels. One Health approach is certainly a challenge for us, and a frequent self-prescription in health and animal sectors, you see. That is one of the big challenge. Insufficient government funding and government patronage, you see. Those were the main gaps that we found. The opportunities that exist, there are labs that those could be upgraded to do drug sensitivity testing while engaging the public-private partnership models and regulation models of surveillance. There are some examples available for models of surveillance, like in TB program. There are some institutes like institutes of big institutes, Institute of National Health, National Institute of Health, research institutes, agriculture research institutes, which are big and could be, you see, take a leadership role. Willingness at all levels exists for AMR surveillance, including One Health partners. And because AMR, the issues with AMR are recognized by all relevant institutes, but you see the practical steps are missing. Media support are available. There are some experts available in each sector on AMR, which need to be used. So these were the challenges and issues and gaps of AMR. And now the current project that we are implementing nowadays. So luckily we have sufficient time to discuss all this. It's like 30 minutes for us. So that's why I'm little more elaboratively talking on that. So the current project that we talk is One Health event-based surveillance project. Is it a collaborative effort of multiple working? The One Health is a collaborative effort working locally, nationally, globally. Emerging infectious disease is a big problem. Is everywhere at all levels, and you are all must be aware that most of the diseases, like 70% all emerging human diseases, have some origin from animals or vectors. You see, so it's important to strengthen One Health capacities or competencies. So Pak One Health Alliance (POHA) is collaborating with international international ending pandemics. There are, I've already shown you a number of partners, because in isolation, we cannot do anything. We cannot make much influence. So it is in partnership that we are in a position to make a change or shift or to make a real, we can make a difference. So it is like a 30 months long project, and we are rather close to, it's like another 5 months to go completion. The vision of this project is to create an integrated One Health platform that allows early identification of disease outbreaks and facilitate joint response. In this project, we are developing appropriate ICT solutions to enable smart collaboration across multiple sectors. We have to form rules and regulations for integration of new component, because as you know, one of the issues is the main department like health, animal health sector, environment. They are working in isolation, and there are no rules for intersectoral collaboration. And develop some programs on One Health and event-based surveillance, and then develop capacities, timely with demonstrate, create tools, manuals. So those were and one of the important areas that we were supposed to work on this project is develop an integrated One Health disease surveillance dashboard, where the information systems of various One Health related department, they could converge and we can for joint decision making. So the work done till today, and this is a stakeholder mapping exercise, mapping gap analysis exercise of One Health departments, looking at there are multiple One Health departments, both at the federal and provincial level. So we looked at their scope, strengths, and gap analysis. And we looked at the MIS systems that these departments are having to gather information from field, like the MIS system or the surveillance system of the livestock department, of the public health department, of the environment and other department. And it's a quantitative and qualitative analysis. For part one, we looked at the institutional arrangements, we looked at the management and leadership, we looked at the governance structures with respect to with a focus on One Health. And for MIS units, we focused on regulatory frameworks, available not data collection methods, surveillance systems, data management, quality assurance, community-based service, data sharing, challenges, opportunities, why if the data is being produced, what is the what prevents them from sharing, what are the issues, where data standardization, things like that. So it was like 51 key One Health sector, one departments, provincial and national, where we did see this kind of scrolling and examine these sectors. And they were from public health sector, animal health sector, environment, food and agriculture. So one of the crux of this is there are surveillance systems or information systems more advanced in the public health sector compared to other sectors. But in livestock or animal sector, there is also a sector. There is also a MIS system, what was called animal disease and response system, which is evolving, I think, which is gaining, that has been developed, especially in the province of Punjab, and that is getting more consolidated. But in environment and in food areas, you see the MI systems are really very weak and need to be promoted. So the main gaps that were found in this mapping exercise: regulatory framework for One Health, guidelines for One Health functioning, focal units for One Health were not there. The people, you see, there were some people working on One Health, but there's no dedicated unit or dedicated budget available. Public health relatively better established. I said before, public health surveillance systems more established compared to and also the diagnostic laboratories compared to other sectors. Limited authority for data metro data sharing, it was an issue, as I already expressed before. Indicator-based surveillance system do exist, because you see the regular indicator do exist, but there is we could not find any what we can say event-based surveillance system. Now this animal health sector has developed a component on event, which is yet to be implemented, but that has recently been developed. No robust One Health EBS system, joint planning, decision making. You see that was lacking. So these are some. You see our the One Health dissemination exercise that we organize, and that's the training. Because I said that we developed this curricula on One Health event-based surveillance, and we have been organizing the provincial and federal level trainings on this subject. So our project is like providing a catalytic support, catalytic push to One Health. You see, it's not a very big project at this stage, but we are, you see, working very meaningfully with the government and other departments. So event-based surveillance project we have developed a modest EBS component of our project, and we are trying to get fetch like on with the PROMET. They are fetching information from multiple sources. So we are also trying to fetch information from emails, web reporting, you see, media, electronic media, and web report, multiple sectors. So this is the beginning that we have made, and this is also part of our website and the dashboard. You see, in the dashboard, I'll just show. So when we talk about two types of data sources, the indicator-based and event-based. The indicator-based is the regular system, you know, where the data is captured on formally on the regular basis from health facilities, health or other routine service delivery system. Whereas the event-based is like events occurring, and there's no usually not a regular formal system, and you have to fetch or coordinate or get this information from sources, and you have to draw some meaning out of this information. And the most important will be what we call is the artificial intelligence has to be applied here. So this we have the routine systems are there with the health sector, and we have been working. So these two systems were in our project. Ideally, the idea is to try to get relevant information from these two data system, the indicator-based system, and the event, and try to match the information for joint planning, joint analysis, and for joint decision making. You see, because the indicator-based system is sometimes not real, but and its scope of the indicator is also very focused and limited. See, it is working in some areas, because the event-based events you can capture from community or from you see multiple areas. So that would be quite supportive to you, because in indicator, which is a government managed system mostly, so that is unlimited. Because in Pakistan, for example, only 30% of the public population is being covered by the government system. The rest is private, you see, and which is not very well regulated. So this is a main vision behind our, you see, this program, that we need to detect it earlier, verify the disease, and look at the level of risk assessment. Verified public event is very high risk, low risk, and the risk communication. So, and monitor it through a proper mechanism. So the dashboard that we have produced as part of this process is a main objective is to examine One Health disease data for joint planning, Implementation we are doing in stages. We have started with zoonotic disease, and zoonotic disease, because zoonotic disease is common in animal and the health sector. We started, and we are trying to link it with the EBS and through multiple data sources. So this is the, you see, what framework that we are adopting. You see, there are MIS systems, MIS units in health department, in livestock department, and in vector-borne disease programs. So we are trying to link these MIS units in indicator-based and take some priority information to a common integrated EBS dashboard, which is able to analyze it automatically and then link this information and share this information with the decision makers at the end of the day. So there are multiple indicator-based systems currently working in the Promise and Puddle, and these are the systems, and they are producing some information on One Health. We have prioritized like 14 health problems, which could be One Health, which are common in multiple sectors, and we are trying to filter out that particular information. Because, for example, the DSS or DHIS, they are getting information on multiple diseases in addition to One Health. So what we are, because there is no One Health specific MIS system, so our surveillance system. So we are getting relevant information from these systems to put it to a common One Health dashboard, which is on like the popular diseases are COVID, dengue, rabies, anthrax, CCHF. So these are priority diseases, and they are reflected on our dashboard on the real-time basis. We are still working on this. This is not, complete, but we have made a start in consultation with the relevant stakeholders, because the final ownership has to be the government. And we are very lucky that government has recently officially endorsed this program, and they will be adopting at the National Institute of Health, the Pakistan with the National Data Center, and they have adopted because a lot more work, directions are set, but a lot more work is yet to be done in this context. Okay, so this would be capturing real-time, capturing issues and problem, the challenges that we are facing is the capturing the real-time data. We are fetching data, but all the systems are not real-time. They are monthly frequency, monthly or sometime weekly. So the capturing the real-time information capturing is important, has to be ensured. Completion of piloting of dashboard. We have already piloted, but you see the more ownership has to come from the provinces, because this pilot is federal and Punjab province. There are other provinces where they don't know about this project at all. Setting this evidence-based efforts to enhance ownership of the project, because once the project funding is over, it has to be owned. And certainly we are we would be very keen to have some kind of benefit for the promotion of One Health by having some coordination with the Global One Health initiative that has been started by Ohio University. That looks to be very interesting, and I think we would be very much keen to have some connection or partnership with them. Thank you very much. So this is quickly I could cover, and thank you for the time you have slot that you gave to us and to my partner, Dr. Shagufta. Thanks.
Thank you so much. And now I think we can transition to Dr. Zareen's presentation.
Thank you,
And just a real quick reminder to everybody, just feel free to submit your questions as we go, and we can answer them once we're done with the presentations.
Thank you, my dear. Dr. Mursalin, can you please close your presentation so that I can start my own?
Okay, let me close my presentation. Is it okay now?
No, you have not closed yet.
It's not closed.
Screen is
Okay,
being
okay.
shared.
Okay, okay. Is it okay now?
Yes, it's okay now. Thank you.
Okay.
Can you see my presentation now?
Now it's loading. Yeah.
Okay.
And yeah, there you go.
Oh, thank you, my dear. Thank you, Christine, and thank you, Laura, for giving me an opportunity to speak on this August forum. As you have just mentioned earlier, the topic of my talk today is Pakistan's COVID-19 readiness and resilience exercise and way forward. The exercise was conducted in year 20 and 21. Before I talk about the actual exercise that we conducted, let me share with you the COVID-19 situation when we embarked upon this exercise. Though globally, COVID-19 started in December 2019 and January 20. But in Pakistan, somehow we thought that we have closed our borders, so we are a bit safer country. Until on February 26, 2020, the first case was reported in Pakistan. And that was the start of that month in our country. By the time we started this exercise in November, this was a situation of COVID-19. As you can see, the number of confirmed cases were 8,45,000 all over the country. However, the fatality rate was quite low. Around 19 deaths were reported by that time. If you see the population-wise regions of Pakistan, there are 4 major provinces, and the number of the reported cases actually matched, or they were just in line with the population. The most populous province, there are 4 provinces. The most populous one is Punjab, followed by Sindh, then KPK, and then is Balochistan. There are 2 independent areas, Azad Jammu and Kashmir and Gilgit-Baltistan. And Islamabad is the capital territory of Pakistan. So you can see, since Punjab is the most populous province, so more cases were reported over there. And in relation to that, of course, the number of deaths were more, followed by Sindh and rest of the provinces. So by August, September, the first wave of COVID-19 was almost over. But there were some predictions and expectations that the other waves will also hit globally and, of course, nationally as well. So by November, we thought that we should conduct an exercise where we can see how successful our strategy was to deal with the COVID-19 situation in Pakistan, whether we have incorporated some of the lessons we learned from our management of some high impact outbreak of infectious diseases in the country, and what are the gaps and strengths of our system that we should build on and we should be kept in mind while designing our strategies in future. And the purpose of this exercise was to see either we are ready to face this challenge again for the other waves. So most of these exercise was based on real life scenario. That was, of course, the experience of first wave of COVID-19, but some of those were fictitious scenarios as well. What happened? After real life experience, we designed some of these scenarios where we can experience some of the worst situation, some of the more challenging situation of COVID-19. And if that happens, how we will be able to respond to that, or whether we are ready to face that or not. So that was somehow the rationale. to ensure readiness and resilience of our national morale, we conducted our during action review exercise. During action review, because somehow the first wave was almost over and we were just getting out of that phase. And based on the analysis of that responses, we just designed some tabletop exercises. That was a very interesting and novel experience for all of us. 3 tabletop exercises based on the fictitious scenario. I would not say fictitious. That was somehow the challenging scenario or predicted scenario for future. All these exercises were facilitated by Park One Health Alliance, and these were supported by Ending Pandemics. Analysis were somehow facilitated by Sandia National Laboratories. And after this retrospective evaluation, as well as prospective testing of potential scenarios for coming months and years, somehow we yielded very good results. This is somehow the snapshot of the exercise that we conducted. The tool of the study was a questionnaire. It was a semi-structured questionnaire comprising of broadly 7 sections, but a number of subsections. We just kept in mind what were the major areas that we used in dealing that situation of COVID-19. And those analyses or responses were later analyzed. Qualitative analysis was done. We designed tabletop exercises. We conducted that, and after that, there was a after action review. And based on that after action review, since most of the participants were either policy makers or policy implementers, so we set some priority areas based on all those responses. This is again the talk about questionnaire. Since the questionnaire was related to some of the strengths or some of the very prominent gap that our healthcare personnel felt about it. So most of the participants were either epidemiologists, laboratorian, animal health or One Health experts, emergency responders and communicators, airport response because it was considered as an imported disease, so points of entry. They all participated in that, and whatever we designed or discussed, it was all led by the participants. Though Park One Health Alliance somehow moderated all the sessions, but mainly we were dependent upon the opinions of the participants because they were experts of their field. The questionnaire was comprising of these main sections. Epidemiologically, we performed very well. Somehow we were able to base all our definitions as WHO had designed. Case definition, case reporting, data analysis was done, contact tracing, epidemiological operation, laboratory testing, because that proved to be a very huge challenge for us. Coordination and emergency response. In that section, we were dependent upon the interdepartmental, because One Health approach was involved in that. There was not a single department that was dealing with the COVID-19 management. Interministerial coordination, responses, logistics and infrastructure, communication, case management and countermeasures, and especially non-pharmaceutical intervention that actually proved to be one of our very, somehow it supported a lot in the management, and travel, animal health, and environmental health responses. So participants played remote and multi-role, multi-sectoral tabletop exercises were designed. What we did, I will talk about these exercises further in detail later. There were 3 types of tabletop exercises, and these exercises were designed once the analysis of all the responses received by the questionnaire was done by Sandia National Laboratories. We designed near-term scenarios, like within 3 months when we were expecting the second wave of COVID-19. Mid-term scenario, it was kept in mind that we can expect within 6 months, we can expect third wave of COVID-19. And long-term scenario, when we were expecting that somehow by that time, international cooperation will not be available to us. And currently, many international organizations are cooperating to provide us supplies and vaccines and other things. But after 3 years, probably world will be facing economic recession. This cooperation will be no more available to us, and resistant variants of COVID will be another challenge to us. And limited supply and capacity will be huge difficulty for us. So that was a long-term scenario. The participants who participated in that exercise were ranging almost all the fields that were key figures or key, they were playing key role in the management strategy. These were the COVID-19 focal person at national level as well as provincial level, Ministry of Agriculture and Livestock. Chairman Corona Expert Advisory Group was a part of all these exercises. University of Health Sciences in Punjab, being a most populous province, this university was taking a lead in designing all the SOPs and other protocols in the province. Policy and strategic planning, there are two health departments and both were coordinating with this unit to deal with all type of hospital type of scenarios. University of Veterinary Sciences, Allied Health Department. Since all the policies were designed at federally, implemented at provincially, but actually the role played by district health officers at district level or the local unit or municipal level was very, very significant. So they were a part of this exercise at all stages. Ministry of Health and Regulation Pakistan, COVID-19 Master Trainer. PCR was considered as a gold standard for COVID-19. So PCR Lab Institute of Public Health was a focal institution for that. They were a part of this exercise, Director General Health Pakistan. Results of that exercise, especially when we received responses of questionnaire, we clearly categorized into strengths and weaknesses of our systems because we knew somehow we have performed well, but what are the factors where we can build or that were contributing to our resilience in management? Number one was political commitment. That will be very interesting for you to observe that in Pakistan at that time, there were different political parties ruling different provinces as well as national government. At least in my life, I have seen it first time that all political parties, all political leaders joined hands together and there was a firm political commitment to tackle that means whatever we could do. So all parties were on a single forum. Then another very surprising factor was in 2010 onwards, health was no more a federal subject. It was purely a provincial subject. Whatever happened in any province, it was only the duty of the province to take a lead and control that situation. But here in COVID-19, it was all centralized response. Immediately in April 2020, just 2 months or rather 1 month after the first case was reported, the government established National Command and Operation Center. It was operating at federal level, and it was actually the backbone of that governance network that was managing COVID-19 in Pakistan. This NCOC had established a dashboard. It was collecting and analyzing information on hourly basis from all regions of Pakistan, where whatever the case was confirmed or rather reported in any province, it was immediately conveyed to NCOC. So centralized database was established. NCOC was designing all the protocols, all the SOPs, and those SOPs were modified by provinces according to their local needs. But somehow NCOC was a major force behind that. The National Disaster Management Authority. This authority was formed in 2005 when we experienced a massive earthquake in Pakistan. But this was the first time when we actually saw NDMA in its active role. This authority was responsible for centralized procurement of all logistics, all resources, and they had again distributed those resources to the provinces according to their needs. So centralized dashboards for everything, whether it was supply chain, it was data reporting, everything was centralized and provinces were following the lead of the federal government. Since there were lots of misinformation, disinformation regarding COVID-19 on social media, in order to counter that, government had designed centralized communication. So text messages, videos, and voice messages were designed by the government, and they were communicated to all government and private networks. So somehow the same voice was approaching the public, the voice that government or the people can trust. Telemedicine was a concept very much in vogue for decades in Pakistan, but this was only a concept. There was no practical implementation of that. But during COVID-19, since there were generalized or smart lockdown in the country, people could not go to the hospital, they could not seek advices of the doctor. So suddenly there was a boost of telemedicine in Pakistan. So somehow transition to telemedicine was very quick in that phase. Then there were some peculiar factors related to Punjab, and that was increase in the lab testing capacity, because we had, Dr. Mursalin has just mentioned that only 30% of the people were getting facilities from the public sector hospital. Similar was the situation for lab testing. But COVID-19 lab testing was quite expensive in private sector. So suddenly government appeared in the picture, and we enhanced the lab testing capacity. We established 4 major labs and converted other labs into purely COVID-19 labs. So all tests were free and people were no more reluctant to go to the labs, rather lab people were coming to them. Then there was a very strong contact tracing and surveillance mechanism in Punjab, and that mechanism started right from the land entry, air entry, or sea entry up to the household level. Tiger Force was another unique concept. These were the people who were actually volunteers. They were no more a health personnel. They were rather youngsters, students. They just made our Tiger Force, and government patronized them, trained them, and these were the people who actually collaborated with hospitals and healthcare personnel for that contact tracing and surveillance. So that was the additional help we sought from them. A number of challenges were identified by the participants. First challenge was COVID-19 was somehow more concentrated in urban areas. Rather, it was considered a disease of urban people, and rural people were safe from that. I don't know what was the reason for that. Probably these were the overseas Pakistanis who were mostly coming to the urban areas, and they were bringing that virus with them. And rural people were somehow immune to that. So we just ignored all preventive strategies to be implemented in rural areas. We increased the lab testing capacity, but we could not focus on the quality assurance and coordination between the government and private lab system. One Health approach was focused. We did take environmentalists and animal health experts into the management picture, but the truly adoption of One Health approach was somehow missing in that. Then people had another scare. They thought a core team that is managing and designing all SOPs of COVID-19. Once the first phase is over, this team will not be sustainable. There was a need for increased research and development for emerging disease events, and especially infectious disease events. Since public-private partnership was a need of the hours, we could not take that along, and SOPs were not developed for that. So it was more of emotional cooperation rather than based on any set criteria. Efficient distribution of supplies, because there were some hotspots, but we could not distribute supplies to them on timely basis. There were PPEs available, but these were proved to be expensive. Developing country like Pakistan could not afford much. So we tried to focus on local production of supplies. Mass vaccination was expected, but by that time, we were just hearing news that vaccine is about to be ready, but we were just concerned whether mass vaccination will be available, will be feasible or not. Maintain risk communication, because somehow the communication was centralized, but people were suspecting that this centralized communication will not be sustainable. Quarantine facilities were proved to be somehow insufficient. Fiscal and policy planning was another challenge. So based on those challenges, role-based and overall response-based exercises were designed, and after that action review was conducted. 3 tabletop exercises, I'll just talk about that were designed. The first a tabletop exercise was based on short-term scenario. At that time, it was more of an anticipated scenario, but later on, the real-life experience proved that it was not anticipated, it was a real expectation of that. So what scenario we designed? that misinformation is spread about a possible link between the animal outbreak, because foot and mouth disease was somehow being reported in the news in those days. So one scenario was that misinformation is that there is a link between animal outbreak and COVID-19, and there is a localized outbreak of COVID-19, shortage of lab supplies, there is lack of availability of PPE, personal protective equipment, and hospitals have less capacity to accommodate a sudden rise in the number of patients. This was the near-term scenario. What was the 6-month scenario or the mid-term scenario? A wave of COVID-19 has arose in urban areas, and vaccines are available, but in a very limited amounts. And in Pakistan, people are resisting to these vaccines just like they resisted to polio vaccine, because Pakistan is one of those 2 countries where polio has still been positive, because people are resistant to that. So we thought that people are now resisting to COVID-19 vaccine as well. And there is increase in the number of travelers to Saudi Arabia to perform Hajj, and again limited supply of PPE. COVID-19 strains have been reported that are somehow resistant to some of the vaccines, and there is a rapid transmission of that. There are food insecurities and economic recession. And the the long-term scenario was, now the vaccines are very much in vogue. We have vaccinated 70% of the population, but there is still one strain. This was a fictitious scenario. There is still one strain that is resistant to all the vaccines that are available in Pakistan. There is an increased mortality because of that, and people are somehow getting panic about that. And at the same time, there is dengue outbreak in Pakistan. And this was somehow a real life scenario as well, because later on we experienced both these diseases side by side. And we earlier had dengue outbreak in 2011. It was a purely horrifying incident for us. So epidemiology, and based on those tabletop exercises, what recommendations people made, epidemiologically, we were very successful. So people made a recommendation that there should be increased preventive strategy and mobilization in rural areas, because healthcare personnel were expecting that we have already dealt with a number of patients in urban areas. Unfortunately, if we expect the similar number of people from rural areas, we will not be able to deal with that situation. So training on new SOPs of changing variant of COVID-19, because we did conduct some of the temporary and transitional exercises of healthcare personnel, but they thought due to some resistant variant, SOPs have changed, so they needed more training for that. Laboratory testing, yes, at that time we had increased number of laboratories, but people were concerned about the quality assurance with strict monitoring for that. Strengthen diagnosis for COVID-19 by detection by maintaining a stock of supplies and storage capacity, because we had somehow designed a timetable that if case is reported by this time, how much time we should take to complete our diagnosis. And in order to do that, we needed a constant stock of supplies. By the time second wave started, these supplies were somehow deficient in the field. So people just anticipated the same well before that. Additional laboratory personnel and field epidemiologists needs to be trained. This was the recommendation. Strengthen the laboratory network and improve the accuracy of reporting. Emergency response and communication. At that time, that was one of our strengths. So people said that expert advisory units should be initiated not only at federal level, but also at provincial level with the support of partners. Prepare existing public health communication networks, media and community engagement for a possible case and for appropriate response. Enhance existing respiratory disease surveillance, because there are a number of respiratory diseases in Pakistan. So people just suggested that whatever surveillance is being carried out for them, whether it was indicator-based, multi-based, or sentinel surveillance, that should be incorporated in the management or integrated strategy for the management of COVID-19. And they should not be ignored. Improve culture perception of treatment and isolation within the community, because when hospitals were overloaded with patients, somehow we restricted patients within their homes. We just advised them to treat, but to be with their family members. We could not afford them their admissions. So people thought the government is not taking responsibility, because in Pakistan, health is a responsibility of the government. So people were quite critical in that. Ensure vaccine supply cold chain. Case management and countermeasures. What happened during COVID-19? We closed all our hospitals for patients other than COVID-19, because we had no other capacity to accommodate a huge number of patients. So the people only suffering from very critical diseases and COVID-19 were admitted in the hospitals. So people suggested that we should not do that again. Rather, we should take local general practitioners into the loop, and they should be advised to treat patients on their clinic at their level rather than referring to the hospitals. And these GPs or general practitioners should be trained, and they should be given some supplies. They should be a part of that management strategy. Improve data collection and rapidly disseminate information. Train and refresh medical teams in the management of severe acute respiratory infections. Should designate referral facilities for care of patients and map existing public and private health facilities. Again, there was a focus on public-private partnership. Since points of entry were considered as the points where we imported the disease, and during the first phase, these were the healthcare personnel who were solely responsible to manage all the COVID-19. But now people just suggested that we should no more rely on health personnel, and non-healthcare personnel like immigration officers, customs people, security people. They all should be just made a part of that group that should be trained to manage that COVID-19. And they just suggested that there should be airport committees where the airport manager should be a head and the healthcare officer should be a secretary, and they should be responsible to design a strategy for their airport, keeping in view the SOPs that have been designed at national and provincial level. In addition to that, there should be increased number of health quarantine facilities, and there should be a better transportation mechanism of patients from quarantine facilities to the healthcare facilities. And one health approach that was considered to be one of the best approach when dengue outbreak happened in 2011 in Punjab. That was a time when we experienced somehow a huge outbreak, but there was not even a single environmentalist, agriculturalist, or forest department, fisheries department. Everyone was a part of that strategy that enabled us to control that outbreak. So people just quoted that example and said that we should replicate the same for One Health approach for COVID-19. And of course, people were concerned about the logistic procurement and supply management, and they suggested that now the public health and social measures that actually helped us a lot should be focused, and non-pharmaceutical intervention should be made a focus of all the strategies that we designed for that. Supply chain management dashboard will be integrated into situation reports to enable all stakeholders to have an overview of activities and potential risk at country level. These were somehow the public health and social measures. These were almost the same measures that we adopted globally or regionally: personal measures, community-based, environment-based, disease control measures. So people said that now currently we are dependent on the global research. We should conduct somehow a local research, because the situation in Pakistan was not as worse as was in some of the other countries. So people thought that we should take a cue from the global research, but at the same time, we should promote academics, industries, and international governments, civil society groups, and non-government organizations to conduct a local research for that. What was the conclusion for that? That combined retrospective and prospective approach at national level and provincial level enabled us to design a better strategy to deal with the future waves of COVID-19. So people just recommended our priorities for that. The priorities were that whatever strengths we had earlier, we should augment that. We should not lose tempo in that, and sustainability of those strengths should be ensured. At the same time, the recommendations they had made after tabletop exercises about the gaps in our system, the gaps or loopholes should be filled, and they should be just taken into account while we are designing or any type of scenarios or strategies to deal with this disease in future. But whatever strategy is being designed, it should not be wholly solely fixed for COVID-19, because Pakistan is experiencing a number of other respiratory infectious diseases. So the strategy should be a comprehensive one and integrated one with One Health approach to deal with all these diseases at the same time. And the hospitals should not be closed to the public, because during that time of first phase, though our fertility rate due to COVID-19 was reduced, but we conducted another study that proved that our death rate due to diseases other than COVID-19 was more in 2020 rather than the trend in the previous years from 2018 to 2019. So we should keep our hospitals open and take care of our public. And that was the end from my side.
Well, thank you both so much for your very informative presentations. And at this time, I would like to open up the forum for questions. And I know that we have two members of our Global One Health Initiative leadership team on who can also come off mute and participate. I just want to do a quick introduction. Dr. Wanda Singh-Gabrayas is a professor of veterinary medicine at Ohio State and executive director of the Global One Health Initiative. And Dr. Wang is associate professor of internal medicine at Ohio State, and she is the director of research and implementation science for the Global One Health Initiative. So welcome everyone. And I would encourage any of the other participants to submit your questions using Q&A. I know we've already gotten one question submitted that way and answered by Dr. Mursalin, so thank you so much.
Thank you so much, Christine, and thank you, Dr. Mursalin, Dr. Zareen. Wonderful presentations, great experience sharing, and wonderful to see what One Health's activities, COVID-19, public and social measures, and many of the activities. So look forward for the discussion. By the way, Professor Su Wang, she's been full professor for the last few years. So just that. Thank you.
Yeah, I think the question already posed, I think I tried to answer. Because you see, both these topics of One Health and EBS are little new I mean, not new, but not really implemented, you see. Because there are some, whenever you talk about One Health, people talk about where is it being implemented, and you see, what are the best practices. And in fact, in Pakistan too, there have been some good pockets of good experience already done during recent outbreaks. COVID, as Dr. Shagufta has already explained, is a wonderful activity that Pakistan was able to still manage to larger extent, you see, and is rated as one of the efficient countries which was able to manage it because that was also one example, because there was a command and control center, and the participation in that was from multiple sectors, you see, not only health. So again, in dengue outbreak that took place in Lahore a few years back, there was some wonderful examples of One Health coordinate, you see, were created. And there are number of other case studies, and we have already developed we are trying to, you see, in GOHi, we are trying to put some case studies from Pakistan, One Health. But you see, but promotion at the larger scale would need more effort, more energy, more voice, more dissemination, more sensitization, you see. And because if you sensitize people in big meetings, nobody argues against it, you see. People for it, but you see, get it implemented. develop SOPs, you see, and there's a regular committees meeting, you see, probably that is going to work. And we need to all be on toes to implement such programs. Thank you.
Thank you so much. I was wondering, we have one of the great things about these webinars is we have people from all over the world joining. And I was wondering if you could put into context a little bit for us about some broader cultural and political, economic context for us with Pakistan and kind of coordinating this centralized national response. What are some things that have helped or hindered this kind of centralized response that's so critical?
Dr. Shagufta, are you going to take this
Yes,
question?
I'm going to. Yes, I was just trying to type answer. Yes, I would not say that something was hindered. Rather, it was taken as a very positive step. And I just mentioned it was somehow the first instance in our lives when we saw everyone together. We had a constitutional amendment in 2010. Before that, health was a federal subject. But after 2010, somehow provinces thought that federal has no more authority to dictate us. We are somehow leader of our domain. So we will not take any lead from the federal government. But COVID-19 just put them together and there was everything centralized. But what provinces thought, it was a thought not practically exhibited by them, that there were no more expectations of supplies and logistics. Every province thought that they are more important than the other, so all supplies should be diverted to them. But NDMA, that was responsible to make procurement, they just thought their database or the dashboard was a guiding force for them. So they thought if there is high fatality and more number of cases, so they were diverting more resources to them. But the other provinces thought that we are the smaller one, but the number of cases related to our population is quite high. So we just need a similar type of resources. That was one. Secondly, financial problems. Government was facing shortage of money because we were not expecting that billions of dollars and millions of dollars will be needed only for management of one disease. So that was a somehow soaring point for them. But that was dealt amicably because politically all governments, all political parties were together. So whatever the administrative thinking was, that was overcome later on. So to my knowledge, to my best knowledge, there was not any dispute or other challenge that was faced.
Thank you. We do have a new question in the chat. What were the health risks that were associated with recent flooding in Pakistan? And were the lessons learned from the COVID response helpful in response to that flooding?
Yes. What happened? We just made NDMA after earthquake. So we thought that all natural and man-made disasters will be dealt by NDMA because this was a National Disaster Management Authority. But unfortunately, during flood time, we have not seen that active role of NDMA as we experienced during COVID-19, while the problems were same. They needed resources, they needed logistics, they needed database, but nothing was somehow made for that time. Because probably federal government was not that active and it was left up to the provinces that this is a provincial disaster. So this is a provincial subject. Provincial health departments are going to take, just going to manage that. While the lesson learned was that whatever we have done at federal level or provincial level for COVID-19 management, the same practices should have been replicated for flood management as well. Because again, there was an outbreak of infectious diseases. Rather, these floods started just before winter. And in winter time in Pakistan, from December onward, we usually have very high risk of respiratory diseases. So COVID-19 was a respiratory disease. So almost the management protocols and SOPs were same, but probably these provinces had less financial resources, less management strategies. During COVID-19, they just followed what the federal government dictated them. This time they had to design their own strategies. So somehow we were lagged behind. And that was somehow a very painful point for all of us.
Mhm.
Thank you.
Yes.
And Laura, I see you've had your hand up for a while. Do you have a question you'd like to throw in there?
It's a separate question. Well, first of all, I'd really like to applaud the work that PAC One Health Alliance is doing. This is so impressive. It's really, I think, serves as a model framework for many different countries, especially the AMR work, the strategy, the intersectoral collaboration. I'm personally fascinated by the integrated surveillance dashboard. One question I had about sort of how you're integrating data from all these different sources. And again, fascinating that you mapped it all out, found all these different sources and compiled them. But how have you been dealing with integration of all of these different systems when they're all at different levels, like you mentioned, Dr. Mursalin, of, I guess, data collection? So public health is more advanced than the animal sector at this time. So you're getting very different data. How are you sort of integrating that? And, what is your approach at this point is my question.
I think that is a wonderful question. I was expecting this question from your end. You see, at this stage, I mean, you already know, once you are developing information systems, you have to talk about the case definitions, you have to talk about the indicators, you have to talk about how it is to be consolidated, analyzed. All those steps have to be discussed and clarified before you proceed further. And who would be the users of this system, and all that kind of discussion, you see. So probably all this development of, let's talk about the livestock MIS system, and that has taken separately. You see, that has not taken together as an integrated One Health information system. So to start with, I think a lot more work is still to be done in that context. See, we have to talk about this, how you see the common definitions, and you see, and the criteria of information that you see the values and all these indicators. So, but at this stage, what we have done is we are talking about the total number of whatever definition for the CCHF, you see, they have used in livestock. Let them use that. We have two separate, what I can say, sheets. One coming from the public health MIS system, one coming from the livestock department, see. And that for particular diseases. To start with, we are looking at, like for CCHF, like for rabies, have that been reported by their system? Has it been reported by our system too? Like for dengue, you see. So at this stage, it's like a very crude method of making, because that was not done before, and nobody thought about it in our setup, that these MI system needs to be seen together, you see, and some of the information has to be and together. I mean, there are a lot of staff. Dr. Shagufta is from the government side, and a lot of the community-based staff from the health sector as well as the animal sector is already working in the field, and they're working separately. There is no mechanism that they can, you see, target same diseases collectively, have joint planning, either at the higher level. But probably this effort of ours will set a stage where the people will start thinking, because there's a common platform is there now. We are about to, I mean, you see, consolidate and finalize it in coming 2-3 weeks, and it will be visible there, you see, and we'll be able to draw some conclusions out.
Wonderful. Yeah, I mean, I think this is such a wonderful first step that could be adopted by many countries, just getting all the data in one place, letting people see it, and then letting stakeholders see the impact that looking at all this data together really has, how it's all working together. So yeah, wonderful. Thank you.
Thank you.
Thanks. And before I turn it back over to you, Laura, to close us out, I just want to acknowledge a comment that we received from one of our attendees today, that one of the key challenges in Ethiopia and operationalizing One Health is the low level of sharing of data and information between human and animal health. And so I think hearing from the two of you about how that has worked in Pakistan has been extremely helpful to hear. So I just did want to acknowledge that comment in the chat. Thank you so much. And Laura, I'm going to turn this back over to you to close us out.
Great. Thank you so much. Yeah, thank you so much, Dr. Mursalin and Dr. Zareen, for your wonderful presentations. So wonderful to hear what you're doing, and so helpful to all of us for learning what's worked, what hasn't worked, applying these different frameworks and finding ways that we can synergize. And then, of course, thank you, Christine, for your wonderful moderation. And then we will then resume with our next webinar on March 16th. Stay tuned to our website where we will be posting more information about that. And thank you all for joining and for your wonderful questions and participation.
Yeah, thank you for giving us this wonderful opportunity to present our work. You see,
Yeah, it's our pleasure.
And
So,
thanks for giving us sufficient time to say whatever we wanted to say.
well, again,
Thank
our
you.
pleasure. Thank
And
you.
hope we'll be in touch.
Yes,
Thank you, Paula.
wonderful. Bye, everyone.
Bye-bye.